So good afternoon, good evening, and good morning, everyone. Welcome to this new issue in our series of Geneva Human Rights Platform Human Rights Conversations. Our Human Rights Conversations are a series of events hosted by the Geneva Human Rights Platform aimed at discussing contemporary issues and challenges related to the promotion and protection of human rights in Geneva and beyond. I'm Felix Kirchmeier, Executive Director of the Geneva Human Rights Platform and your moderator for the next hour and a half. Today's human rights conversation is looking at COVID-19 certificates. What are the human rights implications? Governments and organizations worldwide have been considering or are already implementing COVID-19 certificates to progressively manage the current pandemic. Commonly referred to as vaccine passports or digital green certificates, they allow vaccinated people or those who have tested negative to SARS-CoV-2 or have acquired immunity to COVID-19 to travel and to access public and private spaces. Yet they can also have significant implications for data privacy and human rights. I have an excellent group of panelists with me today, and I will introduce them in more detail when we go along and I give them the floor. You will hear today from Anna Beduski, who is an Associate Professor of Law at the University of Exeter and a Senior Research Fellow here at the Geneva Academy. Also from Marie-Louise McLaws, who is a Professor of Epidemiology, Hospital Infection and Infectious Diseases Control at the University of New South Wales in Sydney. And from Alexandrine Pirlot de Corbion, who is Director of Strategy at Privacy International. In this human rights conversation, panelists will discuss the implications of vaccine passports for data privacy and human rights. This human rights conversation, I think, is placed at a crucial time when the European Union, but also other states, including Switzerland, roll out their COVID passport programs just ahead of the summer vacation in Europe. And first lessons can maybe already be drawn from the first days of practice in terms of their user-friendliness, compatibility, but also the challenges they may pose. So let me say some words on the technical setting of this meeting. We are in a Zoom meeting, so that means I would like to ask you to switch on your cameras, but switch off your microphones until you get to speak. And also, please note that this meeting is a public meeting and we are recording this meeting to be putting it online then afterwards for those who wanted to participate, but for time reasons cannot be with us live today. In terms of the running of the event today, I plan to have a first round, just setting the scene, giving the floor to each panelist for a very short round of interventions. And then in the second round, we'll look deeper into some questions before in a third step, then opening the floor for discussion with you, with the audience. And I do invite you to already use the chat to post comments and questions that we'll be monitoring to bring them then to the attention of the speakers. You'll also be able to request for the floor in the discussion, so then you can ask your questions directly. Now, if I may go into the first round of the questions, I would like to ask actually all of you, all of my panelists, what is the current state in the rollout of digital vaccine passports? What examples would you give from the European Union or Switzerland, as I mentioned before, but also maybe Australia, UK, others? Are there differences or issues of structural incompatibility? And is there anything already known, say, in terms of plans for further development, expansion, or rather also for clear purpose-bound time limits? With this, I would like to go to our first speaker, to my colleague Anna Beduski. Anna currently leads the UCRI ESRC-funded project on COVID-19, human rights implications of digital certificates for health status verification. And thank you, Anna, for also helping very much in the preparation of this meeting today. You all hear from the title of her project that, of course, she's the expert spot on this. The project investigates whether and how digital certificates for health status verification impact data protection, privacy, and human rights. In doing so, it assesses whether there are effective ways to mitigate any potential risks for those rights, informing decision-making in the area of vital national interest. At the Academy here, she leads a new research project, which we're just happy to launch on disruptive technologies and right-place resilience in collaboration with the BTEC team at OHCHR. So for the general questions, first of all, over to you, Anna, please.
Thank you, Felix, for this introduction and for organizing this event. In a nutshell, I would say that there are a variety of initiatives currently underway. So the aim of these initiatives is to provide digital or paper-based certificates that, combined with identity verification, which is a very important point, allow these individuals to prove their health status, such as the results of COVID-19 tests or vaccination records. So as you have already mentioned, in the general media, we hear different labels for those. In the beginning of the pandemic, we heard a lot about immunity passports, then it evolved towards digital health passports, COVID vaccination passports, COVID certificates. So I'm using the general term of COVID health status certificates, or just COVID certificates here to mean these digital and paper-based certificates that allow people to prove their health status relating to COVID. Now, in the European Union, we know that these certificates have already been formally in place since the 1st of July. There are digital and paper-based certificates in place. They are mainly used for international travel within the EU, and indeed Switzerland and the EEA countries, so the European Economic Area, are also concerned with that. They can also implement those certificates. In England, it's interesting that since the 17th of May, people who have received a 2 course of vaccination, so the full course of vaccination, can have access to the NHS digital application or also paper-based certificates to prove their vaccination status, even though it's quite interesting because today the government has released its review on certificates, and formally they are not going to be requiring those certificates, but they allow businesses to be free to require these certificates as they please. So it's quite an interesting thing. There are a number of private sector initiatives as well, for example, proposing COVID-19 smart apps on smartphones, mostly focusing on international travel, but also concerning large sport events. So if people want to go watch the foot, which is quite on at the moment, these are the uses. Now there are a number of questions remaining about the utility of these certificates, as well as the scientific underpinnings of that, and I'm sure Marie-Louise will treat those, about whether there is a scientific basis to underpin all of that. So I would probably stop there, but it's an area that is fast moving, and it's interesting that we're taking stock of that today, as there are a number of developments in the field.
Thank you very much, Anna, for that first reaction. So if I may turn to Alexandrine Perlot de Corbion, Director of Strategy at Privacy International. Alexandrine leads Privacy International's strategic program, which is centralized around building a global privacy movement and involves working with and equipping advocates worldwide to engage on fighting for the right to privacy. Additionally, in her role as advocacy officer, she works on developing and implementing PI's advocacy strategies, and in particular with its partners at the national, regional, and international level, and carries out related thematic research. So also, first of all, to you, Alexandrine, maybe if you could give us your take of the current state of affairs, like where are you, what's the first issues that come to mind when you see the start of the rollout of those projects, of those vaccination certificates? Over to you, Alexandrine.
Great, thank you, Felix. And I'll build on what Anna already presented to avoid repetition. There are a few things that we're noticing and we've been observing for the last year, because initially, as Anna was saying, we've been using different terms, and last summer we started using the term of immunity passports, immunity certificates, and obviously with increased understanding from a scientific point of view in terms of whether immunity would be possible either in the short term or long term, we started shifting to more focusing on the vaccination or a negative COVID results, or in some contexts as well, including people that have had COVID who might have antibodies, and for that to be kind of the three parts that could be included within a COVID-19 status or health certificate. And some of the things I wanted to point out purely on or directly on the questions that you asked, Felix, around the question, the function and design, it's been really interesting to see how that discussion has evolved, because for us, it really felt that you know, there was already decisions or discussions around the around what it would look like, you know, the form and design of an identity system, and then to think about the possible functions, because there were so many unknowns in terms of how the pandemic was evolving. And when it comes to, you know, what this is basically a sort of, you know, form of an identity system, when it comes to identity system, the form and design needs to be informed by the function and not the other way around. And so that's definitely something that we've noticed across the proposals since we started the discussion the other way around. And even within now what are, you know, sort of approved or proposed uses of COVID-19 health certificates, there's still a lot of discretions or a lot of unknowns. You know, there was a lot from the World Health Organization's initial release of its document. They would be two primary uses. They would be for continuity of care, so that there would be a recording from the moment the person gets their first dose to second dose, but also potential future care that they might need in relations to that, and to be able to monitor and keep track of that. And then the second part was around proof of vaccines, which is the more visible example that we're seeing now would be to access, you know, public spaces, to be able to work, for example, depending on the sector. And importantly, as it's been a lot in the media recently with the holidays coming up, as you mentioned, to use that as well as proof of vaccination to give you the possibility to cross borders in the short term and the long term. But yet there was huge issues there in terms of, you know, within those two scenarios, there are still huge decisions to be made in terms of, you know, how much discretion is given to particular businesses, how much is it going to be regulated by law, can businesses decide to, even if they've not been mandated to. And so there, yeah, the uses will vary. When it comes to the long-term possible use of some of these certificates, again, just going back to the work of the WHO, because I've been involved in their working group in the last few months, in their first release, they did put the intention that whatever they would be developing at the moment, be it, you know, the spectrum of paper-based paper with QR, and then that it would also for the creation of a foundational mechanism for existing vaccines, be it yellow fever, polio, but also potential vaccines in the future. So if in a way, if this worked, they would use it as a basis for future digital, in a way, vaccination or health certificates. On the point of sunset clauses, just the last point on that, I think it's really important to mention this, because that's one of the core principles when it comes to the interference with fundamental rights, be it privacy or others. They're only necessary, you know, can be only justified for a specific period of time where they can justify that it's necessary and proportionate to interfere with individuals' rights. And as far as I know, and others in the group can correct me, especially some of the participants that might have insights into other programs, the only one where I've seen this visibly spelled out, it's been in the EU proposal, that there is a sunset clause that as a global pandemic has been determined to have ended, they would then have to revisit and terminate the program as it currently exists, and then revisit it possibly. But then that would require a whole new set of getting consent, again, from all the individuals, and thinking about what would be a longer term program in place. But one thing I wanted to mention in this introductory remark as well as a final point, is this narrative that we've seen around not just the COVID certificates, but just in solutions that propose that automatically trigger and implicate a lot of concerns for fundamental rights and freedom. And this narrative, this dichotomy, this artificial dichotomy that we've seen from the start of the pandemic in terms of having to choose between privacy and respect of our fundamental rights and responding effectively to a public health crisis. And historically, as privacy advocates, we've seen it in different forms. You know, in the post 9/11, it was privacy versus security. In the data revolution, it's been, you know, privacy versus economic development and prosperity. And now with the pandemic, it's this dichotomy of privacy versus health. And that's not how it needs to play out. There are existing regulations that have exemptions, particularly for these extreme cases, and we need to be utilizing them to inform our decisions moving forward.
Thank you very much, and I'm looking forward to deepen that question later in the next round, exactly on that artificial dichotomy, as you call it, or also the potential trade-off that we see in rights. Let me turn to my third panelist today, Professor Marie-Louise McLaws. Marie-Louise is an epidemiologist with expertise in hospital infection and infectious disease control, and comes at our discussion with that practical background and also that experience background. And I will read out a number of titles of functions that you're holding. They're quite long because it's UN terminology. They tend to do very, very long sentences, but I think it's quite pertinent for the event today. So Marie-Louise, activities include member of the World Health Organization Health Emergencies Program Experts Advisory Panel for Infection Prevention and Control, Preparedness, Readiness and Response to COVID-19. I guess I should write that in the chat, because each of those words actually shows a lot of importance to the meeting. And also member of the New South Wales Clinical Excellence Commission for COVID Infection Prevention and Control Task Force. She was also on short missions with World Health Organizations as an advisor to China and Malaysia during the development of national hospital infection surveillance, and was a member of the WHO Clean Care is Safer Care Challenge program that developed that guidance. She collaborated with Beijing to review the response to the severe acute respiratory syndrome SARS outbreak and healthcare worker safety for Hong Kong SARS designated hospital, and was commissioned by the Commonwealth to review the pandemic influenza infection control guidelines for evidence of protection of healthcare workers. So there's quite a mouthful, but actually I think you come with that very practical experience. And so I also would like to hear from you in a first round, where do you see that going? What's your first take of what we see emerging? And also, I don't know if you'd like to add, also, as you're from Australia, an example from Australia where we also hear that, well, despite all the closures that you had, it seems numbers are going up. So just to hear maybe a little bit what you think of the current use and rollout of those programs in the first reaction. So over to you, Marie-Louise.
Thank you, Felix. Thank you for inviting me to join you tonight or today. Look, as an epidemiologist, my first question is, do you think that vaccines work at 100% efficacy, and can everybody get a vaccine? And the answer to both of those is no, they don't work at 100%. And they have a different efficacy for many different outcomes. They work very well to keep us from dying. They work very well from keeping us from being hospitalized and having severe infection. But the evidence is still waiting for what we call real world rollout of phase 4 trials to see just how well they work for us not carrying a viral load that's high enough to infect people. And we have seen before Delta, Israel provided us with great information about Pfizer, that it worked well even in the elderly. And so that's good news. However, the bad news is that now that Delta is circulating the globe, and the UK have been doing some excellent community testing. The last lot of community testing was 190 109,000 people randomly selected from the community. And what they found was that Delta had moved from being about 60% of samples to a whopping 90 to 95%. Now that's very frightening because Delta has an impact on vaccine efficacy, not for death necessarily and not for hospitalization, but certainly for things like symptomatic infection and possibly asymptomatic infection. And many vaccines didn't have the time or the money to be able to test everybody that were kind enough to be participants to identify whether or not they had asymptomatic infection at a high enough viral load to cause infection. So we still don't know about that, but we're hoping that that doesn't happen, except with Delta, it may well happen. So we've got vaccines, we've got AstraZeneca, we've got Pfizer, we've got J&J, we've got many others, and they all have different efficacy levels, and they certainly have different efficacy levels by age. And in Australia, I'll remind you that we've just had, again, a small outbreak in residential aged care, and 5 residents, elderly residents, acquired COVID. 4 of the 5 were fully vaccinated, and they were infected with Delta. They're elderly, their immune systems don't always elicit a good response. So why I'm telling you this is because if we think that a vaccine passport will make travel between different herds, different communities safer, you need to think very carefully that that is not the case. It may well be when we get a global herd immunity, but I'll just remind you about what WHO is very concerned about, is that the average uptake of the 2 doses in the world is 11 people per 100, just 11. And for 1 dose, it's 13 people per 100. So we've got a partial immunity worldwide at just 24 per 100 people. That is woefully low. So WHO, before the Delta started to circulate the globe, suggested that we needed a global herd immunity at a level of about 65 to 70%. And that would be of our total population. But of course, when you look at it by certain age groups, you try to include in that calculation 100% of people over 70 because they've got a great risk of death. And then you put also in that calculation vaccine efficacy. And we know that low-income countries are receiving vaccine gifts from other countries that are doing vaccine diplomacy that have slightly lower levels. And to be able to get into the COVAX facility framework, your vaccine and be approved, your vaccine has to have at least 51% vaccine efficacy. That's not brilliant, but in a pandemic, you can't be too fussy. So imagine a time when you're in a country that hasn't been able to access the top drawer messenger RNA vaccines, and you can't get into certain countries because you have a vaccine of low efficacy, but it's a good enough vaccine to stop deaths and hospitalization. So I'd ask you to think about the human right for stopping people from traveling. Now in Australia, about 1/3 to about 46%, it depends, of us have had a parent or have been born overseas ourselves. We are a country of migrants, and that's becoming more common across the world. It's very common in my area of the world to have migrant populations. We are multicultural, which means that in a time of stress, you've got families overseas and you may need to go and visit them. Imagine you come from a country where your vaccine may have 51% vaccine efficacy, but you might not be allowed into, let's say, America or the EU or wherever your relatives live. So we have to plan for that inequity, and it's not that difficult. You know, there are also groups in my community that are multi-faith, multicultural, and some of them cannot accept a vaccine that has had, even though about 2 decades worth of a fetal cell line, they can't accept that. If you want the community to be vaccinated, you have to give them a choice. So if you don't, and you've only got AstraZeneca available, then they can't take it for religious or cultural reasons. So where's the human right in preventing them from being able to travel? And then, of course, you've got also the issue of clotting, thrombosis and thrombocytopenia syndrome, which has been a big problem in Australia. We're pretty good at diagnosing it. And of course, we've now changed the rule that says you can't have AstraZeneca if you're under 60 years of age. So that means that everybody that's 60 and over who has AstraZeneca, we might not be able to travel to certain locations because it may be considered to be not as acceptable. So instead of doing that and ruling us out, what about including what's called lateral flow or rapid antigen tests at the border? Now, they aren't perfect, and pathologists get very upset about them because they've got a small but a false positive rate. Not a big problem, except for if you're at the border and somebody wants to turn you away. So then you might have to sit over in the transfer lounge while they're figuring out how to get a rapid PCR test so that you can travel. So there are a lot of issues around this. At the moment, we're accepting return travelers who have had a PCR test at no more than 72 hours before they hop on the plane. Now, one of the problems is that a lot can happen in 72 hours, and a lot can happen during transit in some countries where they are gathering a lot of travelers from very different prevalent levels. So you might get infected even though you've been vaccinated. So you've still got to be tested when you arrive anyway. So don't assume that because you've been vaccinated, you don't pose a risk to anybody. The other issue is, so I've got 2 more issues, if that's okay. The other issue is that how long do your antibodies last for? Now, immunologists will tell you that it's not just your antibody response, it's T cell response, but that's very difficult to measure. The Chinese have a rapid antibody test that they can use, and on their passports, they're going to potentially have the date of your vaccine and the type of vaccine you had, and then your antibody level, just to make sure that you have had a response that is potentially keeping you fairly safe. Now, that's not a bad idea. Rather than using a rapid antigen test at the border to look to see if you're carrying a low but detectable level of virus when you're asymptomatic. And then the third issue is that how long does your second dose last? And do we need to factor in a booster? And what happens if you're starting to travel and all of a sudden your vaccine starts to, I guess, expire? Now, there has been a really nice paper out by a group led by an Australian, and I'm not saying it's a good paper just because he's Australian, but it's a really lovely paper by Miles Davenport, who looked at antibody levels and neutralizing virus and the ability and the vaccine efficacy. And gosh, that vaccine efficacy drops dramatically if you start off with a vaccine that has lower efficacy than about 90%. So you might need to start thinking about boosting at 6 months instead of 8 months. And then what's the cost to that, to the community, rather than perhaps using a rapid antigen test at the border that's a fraction of the price maybe. So there's price, there's safety, there's opportunity. And it's something that we shouldn't be rushing into, to assume that when you want to lift all of your restrictions and you have a vaccine passport, you're okay. Because I'm looking at the numbers in front of me from 7 countries in the EU, and it's that your coverage is woeful, except Iceland. 77 people in 100 is pretty fabulous, because you're really not safe enough to assume that you're going into somebody else's herd when you might have a vaccine that you haven't elicited a good response to anyway.
Thank you very much, Marie-Louise. We covered a lot of ground looking at the public health considerations of passports and the timing actually of when it's useful to roll them out. I will come back just with a maybe a little follow-up question later on to you, looking into the importance of trust of the population, also speaking in public health terms, maybe in terms of the acceptability. You already touched about that for specific groups, but maybe also for the broader population in using such digital solutions. But let me maybe turn first now to Alexandrine. Again, as I said, from Privacy International, to ask you exactly about the main privacy issues around digital vaccination passports. Are we opening actually the door for mass surveillance? And if so, if you spoke also before of, I think, the importance of the time-bound nature of measures. So how else to mitigate the dangers that we pose to the right to privacy? Over to you.
Great, thank you, Felix. Yeah, I mean, as with any, not just a digital solution, but with any system or initiative that requires the fast processing of personal data, you trigger privacy concerns, and I'll get into that they're not just privacy concerns, but I'll start with those. But there are also broader issues around fundamental rights and freedoms that will be implicated as well, particularly when it comes to the use cases that have been presented so far around COVID-19 certificates. But when it comes to more of the traditional privacy risks, and some of you that are familiar with data protection will be familiar with some of the risks that I'll mention, because that's basically what it ties to. You know, we have relatively comprehensive, regulations to oversee the processing of personal data in what is commonly known data protection principles and standards. And if those are not followed, there are huge risks when it comes to privacy. And we've seen that during the pandemic, starting with contact tracing apps last year, to then other measures around quarantine enforcement, and then more recently around COVID-19 certificates. The first one is around data minimization. And this has been something that we've, been challenging for a long time. And, as I was mentioning with the data revolution and this embracement that more data is better, there's been really this approach of let's collect as much as we can in case we might need it. And we hear that all the time. It might be useful further down the line, but even this way of thinking goes against the very principles of data protection. And what's really important, that I don't want people to think, oh, data protection is such a dry technical term, because the very purpose of it is really to be able to understand some of the risks that might individuals or communities engage them with a variety of safeguards, either in law or through the use of different technologies. But yeah, data minimization, when it comes to the COVID-19 certificates, we haven't seen a lot of discussion around this. The WHO in their guidance, we're going to be presenting some minimum core data that would have to be saved, and mostly based on their experience of, for example, the yellow fever certificates or other vaccination programs, in terms of what is the data that they need for the two primary purposes that they've outlined, which is continuity of care and verification of vaccination. And so these are discussions, like if that isn't respected at the onset, then it can trigger huge implications in terms of having to collecting more data. That's what's needed. And also linking then to the next point is that if this data becomes available, there's always this temptation that we make use of it. And this issue that I'm referring to is called mission creep. And it's been something that it's really, really hard to regulate mission creep, mission creep is about using data for a purpose for which it was not intended for initially. And the important element here, which comes back to the issue of trust, is if you end up using the data for another purpose, it means the person whose data you collected may not even know that it might be used for that, or changes scope over time. And during the COVID pandemic, we've seen this over and over again. You know, we saw it the contact tracing apps where we were given all these reassurances that, you know, it was only going to be used for contact tracing. A few months down the line, we have a variety of, be it in Singapore, where it was used and accessed by the police, to more recently in Australia, where there was some reports as well that it was now being accessed by the police as part of various investigations. And so, you know, there are real concerns because of, you know, the track record of a lot of governments and companies that are involved of misusing data, using it for their own personal benefit, and along the line, you know, expanding the uses. You know, it creates this really lack of trust and public confidence that the information that we're given at the onset is actually accurate, and that's what the data will be used for. The other element when it comes that's often sidelined, but I think it's really important to take into account here when we're talking about particularly some of the digital solution, is this underlying assumption that digital will be more secure and that it will help tackle issues like fraud, which is very debatable, and mostly a lot of this evidence is unfounded as well, but also importantly by undermining some of the concerns around security and confidentiality and integrity of not only the data, but the infrastructure. It also fails to then consider what would be potential risks and threats which are tied to digital solution around the centralization of vast amounts of data. You know, we've got huge, every day there are news stories of data breaches as well, possibly hacking. And the reason why this is important is that if you don't consider that from the onset, you're not building it, the system, the database, having an approach of privacy by design and default. And then, so if you're not doing that from the onset, you're basically creating a system that has potential vulnerabilities, be it in the software and the hardware, that can then be misused as well. And then another last point on specifically the privacy risks one, because there was a lot of discussion already in the first part of this event about, you know, what are they going to be used for? Do they actually have a justification given the lack of scientific uncertainty, huge issues around access and equity to vaccination programs? There's huge questions still around the legal basis for the processing and the creation of these certificates. You know, the pandemic is evolving. More and more people are being vaccinated, even though not enough, as Marie-Louise was just mentioning. But there are countries that, you know, we saw with Israel, which was one of the first ones to roll it out. Given that more and more people are vaccinated now, they've actually stopped, you know, using some of the certificates. In the UK, you know, we've had various measures opening up our societies and our economies without having to use the COVID certificates yet. And so you start to question, you know, what is the necessity of having such a system in place? And also understanding and link back to my point earlier around sunset clauses, when will they no longer be justifiable? Is it the end of the pandemic? But then if there's a new scope to them, are there further legal basis that governments are putting forward? But just to end and not to preempt too much what Anna, I think, will bring to the discussion next, but I wanted to highlight some concerns, human rights concerns that might not be seen as privacy risks, but are very much tied to and triggered by the processing of personal data and infringement on the right to privacy, the more data being collected than necessary, and what comes within that, the categorization, profiling, and surveillance, not just of individuals, but also communities. And one of them is something that Marie-Louise pointed to as well, given the lack of equity in access, not just in terms of, physically be able to access the vaccine, but also, how are we going to address the number who can't be vaccinated for a variety of reasons, those who don't have access to the vaccine, and might not have for months or years in some context, and those who decide that they don't want to be vaccinated as well, for whatever reason that might be. What is the alternative for these individuals when engaging and participating in society, be it at the domestic level or globally? Will not be able to enjoy their fundamental rights in the same way as everyone else. Do we start and then if we have an alternative, does it single them out as not having been vaccinated? And we've already seen on social media and other platforms the judgment that comes with that as well. And so are we exposing them to further risks? The other thing that I think is really important to mention in terms of the issues around equity and discrimination is linked to my point around fraud and whether the digital is better. And the law initiatives that we've seen, there is this on paper, this guarantee that a paper-based certificate and a digital one will be given the same value, the same trust and recognition, whether at the moment of verification. But we know that might not be the case in practice. Some people might have, you're crossing a border and, maybe showing a piece of paper that might seem more easy to forge compared to having an app on your phone. That might come with different treatments as well to different groups. As well as we know, crossing border is already very vulnerable process where there's huge issues around discriminatory policies and practices based on profiling. And this would be yet another way to start discriminating against certain group, whether they have a paper-based one or a digital one, which might not even be up to them because it might really depend on the country that they're coming from and whether their country has decided to roll out a digital health certificate, or because of means, resources and money and time. For many, particularly lower income countries, they might decide to do more of the paper-based with the QR code. And then, starting to, I think a key area that we've been looking at as well that's particularly concerning is how we've been talking about the monitoring and the use of health data. And usually health data from a data protection point of view has always enjoyed and continues to enjoy high level of protections because of the harms that can result from the misuse and abuse by governments and companies. And so one element here is that with the COVID-19 certificates, it's in a way normalizing, this concept of health surveillance and slowly creeping in terms of, our everyday way of living, some conditions to be able to participate in society. And versus being an extraordinary measures like a public health crisis, it becomes the norm in our society, and that's going to be a very difficult narrative to counter because, as we've seen, over the course of the pandemic, depending on the contact tracing apps or the certificates or other quarantine measures, no single option can exist on its own for an effective public health response. And so putting so much information and so much emphasis on one particular tool risks a lot of this normalization of health data, which is actually something really sensitive and can trigger huge concerns for moving forward.
Well, thank you. Thank you very much, Alexandrine, for that overview of all the privacy issues. But as you say, really going beyond that, looking at discrimination issues, also at the question who is being tasked of checking what further discrimination that can bring. And I think just from own experience from the first lockdown in France, I saw French, German or Swiss police officers clearly not being up to the task and using getting into quite discriminatory practices really all over the place. Also that issue of a two-tier society that might be created. So with this, let me turn to our third panelist, Anna Beduski again. Maybe just to follow up on what was said. So also Marie-Louise mentioned the rights to freedom of movement, for example, and how that could be impacted by a COVID passport, but then also the different levels of acceptance of different vaccines and so on. And we heard again, as I said, just about the discriminatory and other rights restraining issues. So aside of the right from privacy, right to privacy, what other rights, again, would you see concerned? So again, if you'd like to build on what was said before in terms of freedom of movement, assembly, or also freedom of religion as far as the acceptability of vaccines is concerned. And in a more general way, how would you see the right to non-discrimination be affected by the implementation of vaccine passports and the prospective use? And obviously, what safeguards would you recommend should be put in place? Over to you, Anna.
Oh, thank you. Yeah, building on already all the discussion that has been ongoing, we can see that COVID certificates may indeed be used in ways that conceivably can both restrict and also promote the exercise of these freedoms. So if we think about, for instance, a scenario whereby the public authorities would require that people routinely display this health status, so COVID test results or vaccination records to access public and private spaces. Let's say to go to a church, to go to an event like a sport event, to go to a festival, to take a plane, and so any of those. So let's imagine that based on their health status, some people would be allowed to move freely, right? So that would be the case of those who would have tested negative for COVID-19, those who would have been vaccinated. If we take the models that are being proposed at the moment, especially in the EU and in other countries. So by contrast, we would have other individuals that would be prevented from accessing specific places within the territory of their countries of residence, but also prevented from traveling. And that would have an impact on the exercise of their freedom of movement, on the exercise of their freedom of peaceful assembly, also freedom of religion from the point of view of if these certificates are required for entering a place of cult, a church, or something like that. Also relating to what Mary-Louise had pointed out, some people might, for their religious views and religious reasons, not be willing to get vaccinated. So such restrictions on freedom of movement, assembly, manifestation of their religions or beliefs may be motivated by public health interests, which constitute a legitimate aim under, for example, the European Convention on Human Rights. And that builds on what Alexandrine was already mentioning about this question of, let's not put it as a dichotomy that is perhaps artificial between enjoying privacy and rights or public health. These are systems that have been created. Public health interests are protected within the scope of these rights as one of the legitimate aims that can be used exceptionally in situations like the one that we have. Still, measures would need to have a clear legal basis in domestic law, respond to a pressing social need, and be proportionate to the aim that they undertake. So, for example, public health, the protection of public health. Thus, clearing the tests of legality, necessity, and proportionality. So arguably, such measures, let's say requiring COVID passports or COVID certificates, could preserve the freedoms of those who do not have the disease, who have tested negative, have recovered from the disease, or have been vaccinated. And some scholars, especially in those looking at the ethics of that, have argued that restricting the rights of some people in society may, at the end of the day, contribute to avoiding restricting the freedoms of the whole population. So, arguably, we would think that that could be a solution. But I would put to you that we need to think whether this is the least restrictive viable solution. And even though, yes, we could think of it this way, we might restrict the freedom of movement, freedom of peaceful assembly and religion of some individuals, but that would be in order to avoid imposing an even more restrictive sort of measures, such as a full lockdown. But then what we need to really think about, I think it's not to think about it in these terms, but it's to think about what are the conditions linked to the implementation of these COVID certificates. Because we know that depending on how they are implemented, they may lead to the exclusion of populations based on their health status. That can be, for example, the case of those people that cannot have, those persons that cannot have access to the vaccines because of many reasons, or people that would be in a country where, as we're already mentioning before, that do not have the type of vaccines that are required in other countries, especially if we're thinking about global south versus global north, where the types of vaccines that we have in Europe are not being accessed by people in lower income countries. And that is a real problem. But there is also a problem with tests that would be, for example, used as alternatives to vaccines. So if we think about an alternative to vaccine, someone that cannot have a vaccine or do not want to have a vaccine for any reasons could have a test, and thus also use the COVID certificate. Well, there I would put to you that these tests would need to be affordable to everyone, because otherwise we would have a requirement of COVID-19 health status certificates for travel, for assessing public and private spaces, and that would risk reinforcing these inequalities in societies if these tests that are underpinning the showing your health status with these COVID certificates, if these tests are unaffordable for some parts of the population. And that could risk creating a system whereby only the wealthy would have access to mobility and to services. Just to give you a few numbers here, the costs of COVID-19 tests at airports, if we're just thinking about mobility, international mobility, vary significantly worldwide. So PCR tests cost range from $8 to $404 around the world, whereas rapid antigen tests cost between $2 to $214. So now, if we have the tests that range on the more pricey side of this spectrum, that would exclude a lot of people from this international mobility, for example. And if we think about tests that could be required, or vaccination records, but tests as alternatives to vaccines for people to go back to work, let's say, and that could be the case in certain countries. For example, in England, businesses would be able to require that if they please. Obviously, they would have to comply with the legal requirements, and this will not be done in a legal vacuum, obviously. But still, if the costs of these tests are very high, then many people could be excluded. We see that would be something very, very important to be thought about. That's why, and this is one of the findings in my research, and one of the policy recommendations is that policymakers should ensure the availability and the affordability of COVID tests, and also the availability of vaccines to the whole population, to avoid really creating this two-tiered society whereby only the wealthy would be able to move freely and access services. And then still another issue that could be created, even if we think about availability and affordability of tests and vaccines, and you already started talking about that, is this question of how these certificates are implemented in practice. So what would be the practice in the different countries? So would it be that those having a digital certificate would be in a more advantageous position than those that would have just the paper-based ones? But also, if we're thinking about the uses of that domestically, so within the country, let's say to go to the restaurant or to go to a stadium to watch rugby or football or whatever, then we might be facing that famous question of having someone at the entry, at the door, like a bouncer, that would let people in or not. And there is an amount of discretion that goes with that. And perhaps it's not something that we want to see, because we're looking at something that relates to public health, and we're in the middle of a pandemic, and we shouldn't be adopting measures that would lead to the exacerbation of the already existing inequalities in our society. So it's something that needs to be very, very carefully considered. And I think that's why it's important to reiterate what Alex just said a while ago, that these certificates and any other measures that are adopted within the scope of this pandemic stay within the scope of the pandemic, that we don't prolong them, because there is a real risk of, let's say, we would have a digital wallet that has our certificates, so our COVID tests, our vaccination records. It is very easy technically to have other types of information put in this wallet, other healthcare information, our GP, general practitioner's health care information, or any other information. And there it would be very important to have meaningful and truly engaged consent of the populations, if someone really wants to have that, or if it's something that would be just rolled out a little bit by the back door. And again, some people might be excluded from that, and we risk creating this two-tiered society. So these are considerations that needs to be taken very seriously, and we're not yet seeing this being built on the legal basis that would allow the deployment of these certificates. So something to still be concerned about.
Thank you very much. Thank you for the concerns, but also the ways how you see possibilities to mitigate the issues we're seeing. I would like to open soon the floor for comments and questions. We have received some already via messages, but I again would encourage you also, if you want to take the floor and pose your questions yourselves. So while we are still looking at what's coming in, one quick return to Marie-Louise also, as I said before, because we have been talking a lot now about that acceptability and where things are going. So again, if you would like, Marie-Louise, maybe to comment on the current level of trust in those solutions that we are seeing, and also what it would mean, not only from a human rights perspective, but also say from a public health utilitarian perspective of bringing, rolling out programs that really do make a difference. So where do we need to care most to make sure we keep that trust, and how important is that trust also in implementing those programs? Just for a short intervention, back to you, and then we go to the questions from the audience.
Okay. Thank you. Just before I talk about trust, which I think is really important, and transparency of data, which also creates cooperation and trust, I'd like to sort of pick up just vaguely a little bit on Alexandra's and Anna's point about do we go digital or paper? And I'll remind all of the participants listening that around the world, not everybody is privileged to have a smartphone. And, you know, these digital certificates need to be able to be accepted, but how do you ensure that they don't overlook paper? Because not everybody has funds to get a smart telephone, and that shouldn't stop them. And the other issue is this privilege again that I'm concerned about of opening up these borders with these passports, because most countries have a rollout system that's based on a compassionate framework that the COVAX facility developed, and that is those with disabilities, those that work with people who are in hospitals or residential aged care facilities, or frontline workers, or quarantine hotel, and therefore, sure, they can go and travel, but everybody else can't. So you've got a big group of people who can't travel if they would need to go and see relatives. And interestingly, it's that, you know, 18 to 39, that group that are really having most infection, and therefore, you know, pushing sadly the cycle, they haven't been vaccinated yet. And what is the ethics of that? What's the human right of that issue to protect them from infection? But talk about trust. So in Australia, just to give you an example, the government went to an awful lot of trouble and expense to develop a smartphone app called COVID Safe app. And you logged onto it, downloaded it, logged onto it, and it would pick up people through a wall or a glass wall, which was problematic because that means that they're not necessarily a contact of yours. And it was supposed to help with making contact tracing rapid. But while people sometimes downloaded it, it wasn't a true informed consent, because the custodians of the data was an overseas company. And that overseas company has to abide by their country's law, law. And that means that their High Court or Supreme Court could demand that that company provide them with data if they think, for example, somebody in Australia is in a terrorist group or not paying their taxes. And so the population weren't explained about that. And so when it was, which of course I helped tell them because I found it really obnoxious that they weren't being properly informed about this. A lot of people didn't use the app, but nevertheless, we've got about 31,000 cases in Australia and only about 7 cases, well, that's a single digit, 7, not 70, not 700, not 7,000, 7 cases were really found using this app. And I think it was an example of a lack of trust. And that's really sad because once authorities lose the trust of their people, it's very hard to get it back when you're talking about important personal data that they may have. Now, there is a mathematician in America called Po-Shen Lo, who has an app and it uses something completely different. Apparently, if you're positive, you can put your information into the app. It's on your phone. It doesn't come up as your name or any identification, but what it does use is your social network. And then that sends out to other people attached to your social network, 1 degree, 7 to 10 degrees, how close they are to a case. Now, it doesn't help the contact tracers, but it does change maybe behavior, and maybe people might feel more inclined to control their own data.
Thank you very much for that addition and looking into also the good and the bad example that you gave from that. So now we have half an hour left still in the event, and I'd like to pick up on the questions that have reached us. And again, to all of you, feel free to post your questions in the chat. Also raise your hand, even, well, if you have the camera on, your real one, otherwise electronic hand, so we can call on you to make your comment and ask your question yourself. But let me start with 2 questions that I'll give to actually all 3 of you to react to shortly. I think they both actually look again in what came up before, questions of inequality, and discrimination. So we have a first question which relates to the access to vaccines for refugees. The comment was that vaccine administration and distribution for refugees and in areas affected by armed conflict is challenging. And in such cases, return of refugees to their home countries is further hindered. The question, is there a basic right of refugees to have access to vaccination and healthcare? And secondly, how can this be ensured? And are there any programs being run by countries or organizations for refugees? And if I may add myself, just because we had yesterday a discussion on authorities' reactions in peaceful protest related to COVID, and actually also heard about the example. So it was not refugees, but it was migrant communities, Indian migrant workers who were turned back at the border when wanting to come back to their countries because they could not prove, it seems, that they would be free of COVID. So again, that issue of really marginalized communities restrictions to right of movement, or even like to the right to return to their own country. The second question that came in is regarding human rights of people who have not been vaccinated. So here it's more the global perspective, global inequalities. So saying that in the global south, many people are yearning to be vaccinated, but governments are struggling with vaccine scarcity. You mentioned that as well before. And the question of that, with that, in such cases, what can be done to ensure that the enjoyment of freedom of movement is protected? Well, you have addressed that partially before, but just to give you those two questions that came in, and if we, anyone who wants to pick those first, I'd like to give it to all three of you. Anna, please, yes.
Yeah, happy to pick on this question. So on the first question about access to vaccines by refugees, and especially in situation of conflict, I think that's a very important topic, and it's a very important situation that needs to be addressed. I think there is a scope for doing better, and then we would have the humanitarian organizations in the field working on that. And I would just point out that there was an excellent talk organized by the Geneva Academy a few weeks ago, one of the IHL talks that was exactly about access to vaccines in situation of conflict, and something that I think it's available, is still online. So if you want to have a check on that, that's quite an important point. But yes, I think it's not yet something that is solvable and solved at the moment. So something that is of concern. More globally, thinking about migrants, there is and asylum seekers, for example, that are within a territory of a state that is running vaccination. So not in a situation in which they would be in a camp, but within the territory of a state that would be running these vaccination campaigns. There has been a lot of concerns about populations that would be in an irregular situation, not wanting to come forward to receive the vaccines because they would be identified, and it's a valid reason. So there are some places that are running these campaigns. For example, in Rome recently, in Italy, they have been running campaigns whereby people would come and get the vaccine without having to be identified. And I think that's good practice in the sense where we're not linking the identification of individuals with the vaccination. And for public health concern, I think it's a good one. And then globally on the inequalities and vaccine scarcities in several countries, I think that's something that is also quite of an important topic, because we know that in many countries, people will not be receiving the vaccines that we might get in Europe, and that they would not be then allowed to travel. So to give you an anecdotal example, some of my friends and family members that are in Brazil have been vaccinated with one type of vaccine that is not one of those that would be recognized in Europe, so they would not be able to come visit, and that's something that is quite concerning. So there is a lot of these tensions at the moment, and we need to move forward with the vaccination campaigns in these countries, but also with this normalization of what type of vaccines are available, and with the alternatives that would be testing and tests being available, but also affordable to people that would want to travel.
Thank you. And Alex, I think you want to go next. Alex, please.
Yeah, thank you for those two questions. Just to add on to what Anna just outlined, for the question around access to vaccine for refugees, it's definitely something that we've seen happen in various countries. And if I recall correctly, in Lebanon, it was definitely one of their concerns in terms of both refugees, but also persons within irregular migration status, as Anna was saying, out of fear not coming forward, even though there was nothing necessarily in the process itself that prevented them from accessing in terms of having to provide an ID requirement. But just 2 points on that. linked to what I just said, I think one of the ways around this is to minimize or enable the access to the vaccine so that there aren't such requirements that create and trigger this fear. And it's not been consistent in different countries. In some countries, you have to provide a national ID card. In other countries, you don't. In some, it's through your health system, where you might have a health number, but not necessarily a national ID. And so one way around it would be to start removing those practical barriers to be able to come forward and access the vaccine. The other one, which I think this pandemic has provided this opportunity to reflect of how we use data and technology in a variety of sectors and the implication that this has, as we've faced in the last 15 months, but in countries where there's this hostile environment that's been created for such populations, be it refugees or other migrant populations, you know, this creates this environment where there's no trust in the public authorities. And as Marie-Louise was saying, you know, if there's no trust, then people won't come forward. And I think we really need to take the time to reflect of decades of very poor refugee management and migration policies, which means that really hindered some of the efforts around the pandemic, be it to access primary care for people that were sick and infected with COVID, or now in terms of getting access to the vaccination. And we need to address them because there might be something else in the future that comes up. And if these hostile environments are still in place, we'll face the same problems the next time. The other question around the inequality in terms of access, you know, the reason why there is these differences is because governments have decided to create these artificial requirements of which vaccines are accepted, what you need to show to cross borders. And so one way around that would be, again, to not make them mandatory and provide an array of alternatives to enable people to enjoy their fundamental rights. Like, these are not triggered by the COVID virus. They're decisions that are made on a political level. And if we want to address them, then it has to be resolved at the political level and not just at the public health level of decision making.
Thank you. Thanks again for addressing those issues. And also over to you, Marie-Louise, if you'd like to add something on those two questions on the global inequity. You spoke also before when mentioning, I think, the percentage of population there being vaccinated in some countries, but then also the conflict issues, the migrant and refugee status. So over to you.
Yeah. Thank you very much. Look, we in Australia have a mixed reputation, rightly so, for the way we treat refugees. I'm going to tell you a story that is they're not refugees, they're Australian citizens, and it is a great shame. And I think Australia should be shamed for this. So we, as I mentioned, we have a lot of people that go overseas for work, but they also go overseas for family as well, and then they get stuck there. And we have a quarantine hotel system. So return travelers have to go into a quarantine hotel for 14 days, be tested a couple of times during that time before they're released. The numbers of returnees and business people coming into the country got to such a stage at an expense that they decided that they would charge Australians for this, or anybody coming back. So I find that very difficult because, you know, it's very privileged, you know, it's expensive and it can cost thousands of dollars a day. So there's that issue, but we have Indian Australians. Now, it's my understanding that in India, you can't have dual citizenship. A lot of Australians have dual citizenship, but if you're carrying an Australian passport, you should be allowed to come home when you have to. And so we have a lot of Australian Indians who are caught in India with Delta raging, with people dying, not being able to get into hospital. And our government decided that because we at that stage had 26 breaches in quarantine, I had calculated about 21,000 cases had been caused by these multiple breaches over just over a year. They decided that they would put a cap on returnees, and you weren't allowed back, and they would test you, and if you were positive, you couldn't come home. Now, that's one thing. You wouldn't put somebody who was sick with the virus in an aeroplane, but surely there's a duty of care. I put to your participants, there's a duty of care that if you test them, they're positive, then put them somewhere safe. You know, your consulate general needs to put them somewhere safe so that they can get some medical assistance in a country that their medical services were overrun, so much so that people couldn't even get oxygen. So there's that problem. And then given that we've now put in this 50% reduction in people returning, then why not help them to return and start sending vaccines over, to at least start one vaccine to get them home safely, but to keep them at arm's length because you're worried about them bringing Delta home and not doing anything to help them. I'd like you to answer that human right issue, because I find it reprehensible. What was the other question I was supposed to answer? I'm sorry.
Well, it was about the global inequality also from people, but I think you answered that also before when you spoke about the low percentage and actually how it's the problematic. So I think the other side would be the solution, if you want to add later, maybe also on a potential solution. But I think the problematic, you pointed that out clearly, of those vaccines that, as Anna mentioned also just a minute ago, are just below the threshold required by some countries. But I think we identified the problem. We're still short of a solution here, because it's also, as it was said before by Alex, a political problem to be looked at.
Yeah, I'd just like to add to Anna's statement about the rapid antigen test being a fraction of the price of PCR, and she mentioned that they're between $2 American and $214. In Australia, we have at least a dozen that have been approved for use, but they're not allowed to advertise that they have what we call TGA, therapeutic goods approval. They're a fraction of the price. They may be up to $15 American each. Now that is a method of testing people who can't get vaccinated for religious reasons, medical reasons, or just they choose not to, and test them. And if they're in that pre-symptomatic period or have no symptoms. So there are ways around this. It's not just a vaccine yes, vaccine no, and you can't travel if you don't get vaccinated. Thank
you very much. Thank you, Marie-Louise, for that. I see there's someone sharing in the chat also personal history of tests or vaccinations. So I let also people pick up that discussion separately in the chat, who feels like they could contribute to that discussion. There are also more questions coming in, and I'll go now for a last round in view of time. We come close to the end of our session today. So a question that came in was maybe also once now more on the technical side. I think it's interesting to look at this side again as well. It's a question regarding the interoperability of contract tracing tools or systems as proposed by the European Union, how and whether it can be achieved. So the question is, what are human rights implications then of achieving the interoperability? And I think just looking at that question, I see two things. One is like the human rights question of the obligation of states to make those things connected and in a way interoperable, if that's a word. So basically making them coherent, but also maybe the problem that interoperability could bring from a human rights perspective in terms of who will all of a sudden be able to access your health data. So for me, that's a two-pronged technical question that I'd like to put to all of you. And then I see in the chat, if I'm just reading that out, but again, if I'm misreading it because it's a long comment, I'd ask the person also to take the floor. herself. So it's in relation to religious groups. And what actually, so we did discuss before the freedom of religion, so I think that's quite an established discourse. But then also she asks, what about populations that do not want to be vaccinated for cultural traditions, or those who do not see vaccinations in general as an effective or safe health tool? How do those monitoring systems or vaccination requirement impact the right to traditional and complementary medicine, right to traditional and complementary medicine? I don't know if that's that established that way, but definitely where we see the question is that that often we talk about the protection of certain groups as the right is developed and really established in that area, but it might just as well apply to others where it's less clear stated in international human rights terms. So I think it's a very interesting question also as it broadens up again that discrimination question. So with those technical and more moral or also broader human rights question, I would like to give those two back to you. And also with that, ask you to do also include any concluding remarks, reactions to each other's if you wish, as we have about 10 minutes before the close of that session. And now if I could start maybe with Alex, and then I come to Marie-Louise, and I close with Anna. So Alex, over to you.
Yeah, thank you for that question. And it's something I'm going to draw a lot of parallels in terms of the work that we've been doing on, for example, migration databases and proposals in the EU for interoperability between these different bases. And some of the concerns we raise here, I think, we reflect a lot of the concerns we would have when it came to COVID-19 certificates as well. I mean, one of the ones that's linked to what I was mentioning earlier is, you know, this way of centralizing all of this information together would just enable and expand the opportunity for further profiling and discrimination in terms of being able to, you know, have access to vast amount of, not only having access to vast amount of information, but be able to run various search terms or key terms as well, and how that would then be used and for what purposes. And often when we're talking about interoperability, there's very little discussions about issues around, you know, risk, cybersecurity, privacy and data protection that need to be considered as the interoperability is undertaken. Another area also linked to some of the safeguards that would have to be put in place in terms of respecting the data protection principles and standards would be around data retention safeguards. When you start looking at things around interoperability, it raises a lot of questions about absences on limits of retention, you know, as well as access and permissions that need to be regulated to that information in order to minimize some of the potential interferences with fundamental rights and freedom. And then there's also the concern as well in terms of, you know, what they're proposing to do would be, you know, very complex and ambitious, and the risk of failure is potentially quite high, and yet huge decision and life-changing decisions, as we've been talking for the last hour and a half, would be made on the basis of that information in terms of, you know, providing access to different services, be at the domestic level, or also be able to travel abroad as well. And one area that I didn't mention earlier, but that's very important, be it in the relations to interoperability or even just the creation of themselves of some of the COVID-19 certificate and associated databases and systems, is around the impact assessment. It's definitely something we've not seen, or at least has not been publicly shared, or the findings haven't been publicly shared as well. And unless you understand what could be some of the potential risks that emerge from this, and the impact it could have on fundamental rights and freedoms, be it at the individual enjoyment of fundamental rights and freedom, or groups, as we talked about, refugees or migrant populations, then you have hardly any information on which to be able to identify what are the safeguards, be it technical safeguards that need to be implemented, or some of the legal and regulatory one. And so, like Anna was mentioning, in terms of being able to do, you know, this assessment of the proportionality test and the necessity test, it becomes very, you know, almost impossible to do if you don't have that initial information about some of the impact that might result from that. And then the last point is really linked around the failure to consider some of the potential security risks in terms of ensuring that, as I was mentioning earlier, from the onset, you have privacy by design and by default, and that the system itself not only supports but enhances privacy rather than undermines it. And so that's something that we'd be worried about if the safeguards are not in place, which may lead to vulnerabilities in the system and allowing misuses, abuses, be it breaches, or a lack of management of permissions and access to some of those databases.
Thank you very much. Thank you, Alex, for that. And over to Marie-Louise, please. So also again, with those two questions that came from the audience, but also maybe other points you'd like to add before the end of this meeting.
Look, I think I'll add to Alex's theme, and that is contact tracing data. So in Australia, we do a lot of contact tracing. You know, it's you know, testing, contact tracing is part and parcel of how we control the spread. And it's very interesting to look at the different states. They're like provinces. And in one province, it's on that questionnaire, it says that these data won't be shared with anybody outside the Department of Health. And yet, interestingly, they use the police, and I can't remember if it was Anna or Alex that mentioned police, you know, getting involved in making sure people stay at home. And so all of a sudden people can have the police turn up on their doorstep to ensure that they're actually at home if they're being asked to quarantine at home. And so that is interesting and potentially problematic, unless for some reason in that definition of the data won't go outside the ministry or the program, somewhere in the fine print it says that the police are included in that. In another province of the New South Wales, which is the largest state in Australia, there's absolutely nothing on the front page of the contact tracing form that says your data will be kept confidential, and there's an assumption it will be. So what I'm concerned about is there needs to be a very, and I'm not a lawyer or human rights expert, as you know, but what I'm very concerned about is that later on, when groups become litigious, businesses become litigious because somebody has caused a lockdown, could these data be accessed? So I put it to you, the human rights experts and lawyers, to think about how to deal with that. And I think that's my last happy statement.
Thank you for that one and that challenge also, because obviously we get into a very strong legal question here. Over to you, Anna, to also again react to the questions or also to each other's statements. The questions again were the technical and the more moral and wider human rights protection in question. And again, any concluding comments you may have.
Well, thank you. Well, so just reacting on the first question on the interoperability. Well, if we define interoperability as the way in which different IT systems can read the data and can understand that data, they will need to be interoperable if we want to have certificates that are readable from one country to another. But I think, as Alex was pointing out very well, it's not just a question of whether they're interoperable or not, whether this interoperability is in place or not. It's a question about who has access to the data, when, for what purposes, and for how long. And I think, and what are also the security measures that are in place, so cybersecurity measures in place to prevent this data to be breached, prevent breaches in data protection, and also the questions about the confidentiality of the data and what type of data is going to be accessed by whom. So I think that's that's more what is at stake. It's not just the technical side of having IT systems that can read the same data and can understand that, but it's more about these other issues that in a way are much more political than technical, because there are political decisions about who has access to what. And on the second question about the human rights implications that were more broad, I think we touched upon those, and I think one key point for the COVID certificates is to have alternatives in place, and these could be tests. But insofar, to my view, insofar as these tests are affordable to populations, and insofar also as the campaigns are done in a way that do not prevent or not have a chilling effect on certain populations that will not want to come forward, as we have discussed about migrants in situation of irregularity within the territory of a country. So I think all of this needs to be carefully balanced. And I would end that. One of the things that one of the key research findings in the project that I'm currently leading on COVID certificates is that there are three main points that needs to be addressed, and it is relating to, first, the context in which the certificates will be deployed, secondly, the impact that they have on the rights, and thirdly, what are the safeguards in place. And these can be very, very important, and we have been discussing all of them until now, but comprising sunset clauses, comprising data protection impact assessments, privacy and data protection by design and by default, and also these broader considerations relating to equality and discrimination. So I'll end there because I think we're running out of time, and thank you so much for listening.
We are indeed running out of time, but thank you so much for those very rich presentations. And also, Anna, especially thank you for ending with the 3 bullet points of practical outlook, because I think otherwise we were looking also sometimes at quite bleak pictures. I think a takeaway point here is definitely for governments or companies rolling out such plans of certificates or apps, is that human rights safeguards need to be in there by design. Also from a very utilitarian perspective, really to see that to ensure acceptability, because probably in all countries except very well functioning dictatorships, a disregard of that makes this programs just useless in the long run if populations will not accept those. I think also we saw that we are in an exceptional situation, and like already with the vaccines themselves, we see also the testing of those COVID passports and other apps just moving the testing phase from the development rather to the rollout in the general population. And so I think it will be quite interesting to see what's developing over the next month, and we'll be continuing to evaluate that situation and probably have another discussion in half a year from now, and it will be interesting to see what the findings would be by then in a field that is really developing very, very fast. Thank you all very much again, Marie-Louise, Alex, Anna, for your contributions. Thank you all for having participated, for the questions that you have sent in. And I'd like to thank also again Anna, but also my colleague Jonathan Andrew, Yasmin Arias, and Chloé Naret for their help in bringing this meeting about. Thank you all very much. And as mentioned, we'll be also posting, if you all agree, this event online, so you can see it live. You can see the IHL talk that we just shared the link throughout that meeting to look into the arguments again. Thank you very much for having been with us today for that human rights conversation, and please do look at our website or register to the newsletter. We respect privacy here, and in order to be informed of upcoming events that we are having on this issue or other human rights issues of particular concern. With this, thank you very much and have a good day, evening, wherever you are. Goodbye.